Hi everybody, Dr. Daniel, and today I'm talking about what should you track in a migraine diary. Well, I was reading an article online of some other headache doctor. He was giving out a headache diary with every patient he met, which I thought was a pretty good idea. It gives you an idea of how important this is to doctors to take care of headache. So migraine is this explosive, genetic, inherited neurologic condition that comes at times you don't know when, and you have to be ready for it and react to it suddenly, or you'll be in trouble. All right, so what are the list of things that would be that you should look at and search and find and document in a migraine diary? Now, the main reason you want to do this is because you would get personal insight and maybe you could discover some trends that are happening on your headaches. It'd be important for you to look at yourself and also discuss with your doctor when you see him. So here's what you ought to track in a migraine diary. The onset of the migraines, the duration of migraines, the pain intensity on a scale of 1 to 10, migraine relationship with menstrual cycle for ladies, sleeping patterns, nighttime occurrence of migraine, stress patterns, dietary foods, medications that are used for treatment, weather change, missed meals, the side of the head involved with your migraines, the time medication was given, and whether or not retreatment was provided. Any accompanying symptoms can be helpful: nausea, vomiting, sensitive light and sound, olfactory sensitivity, the need to be down, whether you missed work or school or personal activities, what your migraine triggers were, and the days you were migraine free. Now I think everybody knows migraine inflames the sensory nerves in your brain. I'm just going to go over that talking about it. So first, it inflames the olfactory nerve, which is the first cranial nerve. So it makes a person sensitive to olfactory situations like smell. Cigarette smoke would be an example there. The third cranial nerve involves vision, the optic nerve, and migraine turns it on so you have sensitivity to light called photosensitivity. And the eighth cranial nerve is hearing. It turns that on so that you're sensitive to sound. So migraine patients want, during a migraine, to be in a quiet, dark room. Migraine can also turn on the vomit center in the brainstem and give you nausea and vomiting. It's a terrible thing. And patients who have migraine with aura may see stars or zigzag lines or holes in things as part of the migraine aura event. Or they may have numbness and tingling. It comes to the fingers, it goes to the hand, it goes up the forearm into the face and the cheek and the tongue, or it may provide trouble talking. So migraine can do all these things in persons with the aura part. Now we think the aura part is related to a cortical spreading wave of depression that goes from the cortex, from the occipital lobe of the back of the head forward toward the parietal lobe, and it just shuts off the neuronal activity for a period of minutes, and then resets and comes back on. And you could track your migraine diary just on a simple notebook you get at the store, or you could use a migraine cell phone app. And I've got a list of that on my migraine blog at drmigraine.com. I've got a whole article on that you might check out if you want to look at it. All right, question number one, who says a migraine has to be a duration of 4 to 72 hours? Well, that's just observed facts about human physiology. Migraine releases neurochemicals in the brain, and these are neurokinin A, substance P, and CGRP. And these chemicals are inflammatory so that they inflame the trigeminal nerve, they make the arteries dilate, gives you vasodilatation, that throbbing headache of a migraine. Then they inflame and intensify the thalamus, which is in the center of the brain, and that's called the pain center. Now, this is a process. It's called the 4 cycles or processes of a migraine headache, and it takes 4 to 72 hours for these chemicals to go away. And they put needles in the neck and tracked these neurokinin, substance P, and all substance P and CGRP medications. They course through the body, and they can see how long it takes to get the liver and how long it takes to get out in the toilet. So we know that migraine lasts 4 to 72 hours because that's how long it takes to get the medicine and the chemicals out of your body. That's not some arbitrary term that's decided by some committee. That's actually relationship with the human physiology of the body. Now, some people will say they had a migraine that lasted a week or a month or 6 months or something like that, and they're not really describing a single episode of migraine, which again can only be 4 to 72 hours, but they're describing chronic migraine. So episodic migraine is 14 migraine headaches a month, and chronic migraine is 15 headaches a month, 8 of which have migraine features, which means then they're throbbing, one-sided, severe, associated with nausea, vomiting, sensitivity to light and sound. What is the pain intensity of a migraine? So if you use a 1 to 10 pain scale, the International Classification of Headache Disorder says that tension type headache is a moderately severe headache. So it could only go to about a level 5, whereas migraine can go 7, 8, 9, 10. And my patients have always told me it goes to 20. They're just being facetious and kind of joking. It's cute, but they're describing really terrible headache. Thinking like that, you can say that any severe headache is probably going to be a migraine. All right, I'm going to talk about the relationship between migraine and estrogen levels in a woman. So the first 3 weeks of her cycle, the brain is sending a signal to the ovaries to produce estrogen. And then suddenly that shuts off and the estrogen levels will fall. And that's when a woman bleeds. And that's when migraine tracks around that time. So what's called a menstrual headache, according to the International Classification of Headache Disorder, is a headache of the migraine type that comes the day of bleeding, 2 days before bleeding, or 2 days after. There are also some migraines that will come later in the cycle, but that's what I just defined previously was menstrual headache. And then the next 7 days of the cycle, progesterone is secreted, the whole thing resets again. So one of the strongest known relationships of occurrence of migraine for a woman is a fall of estrogen given a menstrual type headache. So persons can have migraine with or without aura, and they may have a menstrual headache, or they may have migraines at other times during the month. But there is a classification of ladies who have what's called pure menstrual migraine, and they only have migraines during their menstrual cycle. And most ladies will say that their menstrual headaches are the most severe, the hardest to treat, and the longest. All right, how about the relationship of migraine with sleep? What's the deal here? Well, persons would have migraine, if you study them with sleep studies, they don't sleep well. So there are 4 stages of sleep, stage 1, 2, 3, 4. You learn this in your neurology training. And so deep stages of sleep are levels 3 and 4. Migraine patients in a sleep study only get stage 1 or 2, which is really light sleep. The other fact here is that 50% of persons who have migraine will have depression, because migraine and depression are comorbid. And 40% of persons with migraine may have what's called generalized anxiety disorder. And both of those disorders, GAD, generalized anxiety disorder, and depression, have as cardinal defining symptoms insomnia, trouble sleeping. So you can see how that interacts with the migraine group. Well, even if you don't have a psychiatric disorder of depression or generalized anxiety disorder, patients with migraine just don't sleep well at all. So the performance of good sleep hygiene is really important for migraine therapy. How about stress? Does migraine relate to stress? Well, the number one type of event, like a trigger or aggravating feature that drives migraine all over the world, is stress. And the International Classification treats that as a factor that's accumulative. So if someone has a glass of red wine right now, and like say 10 in the morning, by 11 they get a headache, well, that's an acute therapy reaction, and that's a trigger. A trigger is something that occurs within 24 hours after you do it, it gives you a headache, like missing a meal or something like that. Whereas stress is described as an aggravating feature that's built up over a month. And stress could be, we all know what this is, but stress could be, taking final exams, a mother who's got children and gets all the packaging and cooking and everything she's going to do to have a beautiful Christmas presentation for her family. And then when it's all over, Christmas Day, she'll get a migraine headache then, which is kind of a letdown headache in relation to withdrawal from stress. So again here, stress with migraine could be like taking final exams or taking an interview for a new job or starting a new job or something like that. What about dietary factors in migraine? Well, here we're touching on something that, although there's a lot of data about this everywhere, they're in books and articles have been written in the past, and it's all over the internet, particularly on Pinterest. But the science behind it is really not that good, and we really need good articles to be done about regarding food and aggravation of migraine. And I always tell my migraine patients, if they think there's some food that gives them migraine, then avoid it. Use it as a trigger. Avoid it. The ones that people write about that are probably more secure in terms of being real or scientific are red wine, tyramines, chocolate, and MSG. Those may drive migraine. But again, it's a controversial area that really hadn't been well studied. How about migraine related to weather change? Well, when I was writing my big textbook on migraine, which is on Amazon, years ago, I spent some period of time when I was talking about this, looking at research and reading neuroanatomy books, and there's nothing in there about a barometric pressure receptor in the human brain. There may be some in the carotid arteries here. Maybe that has something to do with migraine, but it's sort of still, to me personally, a mystery where the baroreceptors are in the brain. But we know that they do react, and persons with migraine will have headaches related to barometric pressure change. If you practice headache, you hear this every day, multiple times. And also there are articles written scientifically that show this type of relationship. Don't really understand why, but I believe it. And I tell patients, you can track your barometric pressure on a cell phone, and if it falls, then a migraine may come. And so that'd be a good time to be especially sure that you avoid your migraine triggers and you treat very early if a headache starts during that time. Not wondering, is this just going to be like a mild little tension type headache? No, if it's a headache where barometric pressure falls and you're a migraine patient, you're having a migraine, treat early, use your triptan then. How about missing a meal causing a migraine? Well, I'm a headache doctor. I've been practicing over 50 years, and most people with migraine that go see a doctor are younger ladies. So women have migraine 2 times more than men do. And so headache doctors are full of young women, usually late teens, 20, 30 years old. And my observations there are many of these ladies don't eat breakfast. Even my own daughter won't do that on occasion. And they may get what's called a hungry headache. And you treat a hungry headache by feeding it. So when the blood sugar drops, that sends a signal out to cause arterial dilatation. You get a headache from that. Another question here is, why does migraine just occur on one side of the head? Well, I don't know. I don't think anybody knows the answer to that. It certainly does do that. But why it does it, I don't know. I don't think anybody knows the reason for that. Galen was a special kind of a headache guy in a Roman physician, 2nd, 3rd century, and he described a feature which he called hemicrania. And he wrote a textbook of medicine that was used till the 14th century, Galen. So hemicrania in Latin means half of head, like a hemisphere, where it's half of the globe. So half of head. And so as time went on, they took off the HE part of that word, and you see the word micrania, M-I-C-R-A-N-I-A, occurring in the French literature in the 18th century, and then what was called megrim, M-E-G-R-I-N, in the 19th century. And then finally we got migraine that comes along the 20th century, and that's the word that's been accepted now, migraine. So what is the most common feature of any migraine headache? The most common associated symptom is it may be one-sided. Now, many patients will say something like, I'll have, majority of my headaches will be right-sided, but occasionally I'll have it with the left side. And I'll say, well, that's a good feature, because that's saying that's what migraine does. It comes in an artery and trigeminal nerve on one side of your head, and then it'll go the other side. It means there's nothing wrong on the right side of your head if you only had right-sided headaches. So some rare persons, I don't think I've ever seen a case of this, but I talk about it, persons who've had only one-sided headache may have an aneurysm or an AVM, arteriovenous malformation, or something anatomically wrong on that one side of the head. So the fact it switches is good and benign. All right, why is it important to track the time that the headache came on and when you treated it? Well, That's the most important feature of treating migraine in the world now. Is I spend my life talking to patients to treat at onset of either the aura or the headache. You know, treat and take your medicine right then. You got to pull off the road if you're driving to work and go somewhere and get a glass of water and take your pill, or else take your shot, or whatever you're doing for treatment. Or you got to get out of that board meeting or whatever you're doing and treat at that time. And migraine patients can learn to do this, but if they don't treat early, what happens then, after 20 minutes to 40 minutes after the start of the headache, then the chemicals come out. And currently, even though we have newer drugs in 2020, still the triptans are the best drug for acute therapy of migraine. And if you take a triptan at onset of a migraine, that'll give you a headache-free experience in 70-80% of persons in 2 hours. So triptans are the best drugs here. But if you don't treat early, then they don't work. What triptans do is they block release of neurochemicals. If you don't do that, you're stuck with a headache. Even though they say triptans will work anytime during a migraine, they won't give you a headache-free experience. Why is it important to track and look at medication retreatment? Well, a doctor may look at that and spot and see somebody's taking like Advil or Tylenol 4 or 5 pills a day for a week. Well, that person may get into medication for its headache if you do that, because you're not supposed to use any kind of painkiller, NSAID, Tylenol, Advil, caffeine drugs, certainly no triptan, more than 2 days a week. And of course, no migraine patient is supposed to use opioid narcotics, and none of them are supposed to use butalbital, which is an S-Jec or Fiorinol. Those are horrible drugs. Don't go there. So if you can look at the retreatment schedule, will tell you how often patients are taking medicines, and hopefully they'll limit that to only 2 days a week. Okay, why is it important to track nausea, vomiting, sensory light and sound, and that kind of stuff? Well, particularly nausea, vomiting is important if the doctor is going to look at this list, because I would like to know if the patient does have significant nausea during the headache. And the deal with nausea and vomiting is, my experience is that most patients feel that their medication is causing it, but migraine is a medical condition that turns on your vomit center and can make you nauseated. So it's difficult to sort out the patient having nausea. Is this from the medicine, or is it just plain old migraine doing this and you're treating too late? In the old days, we used ergotamine. Ergotamine can make you nauseated. And we had to treat with nausea-type drugs like Phenergan in those days first, pre-treat, and then you'd use ergotamine. But you don't have to do that nowadays. Triptans, they say 80% of the time, triptans will take care of nausea during a migraine. So I usually feel a physician that if they get nauseated with a headache, it's probably because they're not treating soon enough. But I could be wrong about some of that. That's just my inclination. So you want to track that and look at it. Well, don't you think that migraine triggers are important to notice? This is one of the things the migraine patient needs to discover about themselves and their own body, what are your triggers? Not everybody has sensitivity to light very much. Not everybody has sensitivity to odors. Not everybody's going to get a headache if they miss a meal, but some do. And if you have those features, if you get a menstrual type headache, would come in a day of bleeding or 2 days before or after there's a headache there, that's generally a migraine until proven otherwise, and things like that. So it's upon the person himself, themselves, to learn what their triggers are and then to avoid them the best you can. And that's kind of a learning experience. All right, what's the deal about knowing the days you're headache free? Well, sometimes if you keep a log of these things, you'll look and see that like maybe during September, October, you only had 1 headache a month, and then during December you have 3 or 4. You think, well, my migraines are getting worse. Well, really, that's probably the stress of the holidays and kids home and that kind of stuff. But really, you were just having 1 migraine a month, and so you can see that, and it can be very helpful. Also, physicians will study and look at these things to see about treatment issues there, which is, I think, helpful. Okay, so I encourage everybody to use a good migraine diary to document these issues in them. You'll learn about yourself, and also your doctor will be able to help you when you see them. So it's the end of my talk today. Thanks for listening to me. Please click subscribe down there, and I'll see you again on the next talk.